Hello and welcome to episode 5 of our Cardiometabolic Forum monthly podcast. My name is Richard Donnelly. I'm Emeritus Professor of Medicine in the University of Nottingham in the UK, and I'm delighted to be joined today by Dr. Subodh Verma, who's a cardiac surgeon and clinician scientist at St. Michael's Hospital at the University of Toronto in Canada.
Hello, colleagues. Hello, Richard. It's great to see you. I'm also very delighted to be part of today's CMF monthly podcast brief. As Richard mentioned, this is the 5th episode. I'm Subodh Verma from the University of Toronto at St. Michael's Hospital. Just to remind our viewers that the CMF is a free educational resource for clinicians, and this podcast aims to keep you up to date with the latest information and data in the field of cardiometabolic diseases. In this episode, we'll be discussing 2 very interesting papers that were published in March 2022.
Yeah, the first paper by Shaman et al. Carried out a pooled analysis of the SUSTAIN-6 and the LEADER trials and compared the effects of semaglutide and liraglutide compared to the effects of placebo on kidney outcomes in patients with type 2 diabetes.
And in our second paper, Agarwal and colleagues analyzed pooled safety data sets from the empagliflozin clinical trial program to investigate the incidence of acute kidney events. You can find the summary slides for both papers discussed today at cardiometabolic.forum.com.
So I'll begin by talking about our first paper. And this analysis was conducted in order to evaluate the effect of glucagon-like peptide 1 receptor agonists, semaglutide and liraglutide, on kidney outcomes in patients with type 2 diabetes. And the manuscript provides a pooled analysis of data collected during the SUSTAIN-6 and the LEADER trials. The background to this analysis, of course, is familiar to many of us. Type 2 diabetes is a major risk factor for chronic kidney disease, and a large number of patients with type 2 diabetes will in fact develop diabetic kidney disease in the course of their lifetime. And a sizable number of those will continue to develop kidney failure, requiring renal replacement therapy or transplantation. So the morbidity, mortality, and the costs associated with diabetic kidney disease are enormous. And there is considerable interest in whether diabetes-related interventions, particularly GLP-1 receptor agonists, will slow the progression of diabetic kidney disease over time. So just to remind you, the SUSTAIN-6 and the LEADER trials were both multi-center, double-blind, placebo-controlled and randomized trials to evaluate the effects of GLP-1 therapy. Their primary outcomes, of course, were previously reported, and that concerned the primary outcome of cardiovascular death, non-fatal MI, and non-fatal stroke. But kidney-related outcomes were collected in both trials, and it's those kidney outcomes as secondary endpoints that were combined in this pooled analysis. In SUSTAIN-6, there were almost 3,300 patients. The LEADER trial, of course, had over 9,000 patients. And the inclusion criteria for both of those trials were simply patients with type 2 diabetes who had high cardiovascular disease risk, and they also had baseline levels of HbA1c of more than 7%. In SUSTAIN-6, patients were randomized to once weekly semaglutide, either 0.5 milligrams or 1 milligram, or placebo over 2 years. And in the LEADER trial, patients were randomized either to liraglutide in a dose up to a maximum of 1.8 milligrams subcutaneously, once daily, or to placebo. And the leader trial, of course, was not only larger, but it also had a longer period of follow-up from 3.5 to 5 years. There were 3 kidney-related outcomes that were monitored as secondary outcome measures in both trials. Firstly, the change in albuminuria from baseline to the 2-year visit. Secondly, the annual change in eGFR from baseline. And thirdly, the time to any persistent reduction in eGFR in the region of 30%, 40%, 50%, or 57% from baseline. The baseline characteristics in these 2 trials showed that about a quarter of patients at baseline had an eGFR below 60, and almost 40% of them had an increase in urinary albumin excretion rate at baseline. The total combined pooled analysis included 12,637 patients, of which 6,300 were in the semaglutide liraglutide group, and about 6,300 had been randomized to placebo. So just to look at those 3 kidney-related outcomes separately. Firstly, let's focus on the change in urinary albumin excretion rate at 2 years following randomization. And for the pooled population, albuminuria was 24% lower in the combined semaglutide liraglutide treated population compared with placebo. This was driven mainly by data from the leader trial because it was larger and also had longer follow-up. But in essence, semaglutide 0.5 milligrams lowered albuminuria by on average 20% compared with placebo. The higher dose of semaglutide reduced albuminuria by 33% compared with placebo. And in the leader trial, liraglutide lowered albuminuria by around 23%. The second kidney-related outcome that was measured in this combined analysis relates to the annual change in eGFR from baseline. And it was comparable. The slope of the eGFR decline in the placebo-treated patients in both trials was comparable. And there was a reduction in eGFR slope compared with placebo in the overall study population. And that achieved statistical significance. And thirdly, the authors of this paper looked at the time to any persistent reduction in eGFR. And in the pooled analysis, the semaglutide liraglutide treated patients had a reduced risk of persistent eGFR reduction versus placebo, which achieved statistical significance. So the conclusions from this powerful pooled analysis of secondary kidney outcomes confirms that GLP-1 receptor therapy has nephroprotective effects, reduces urinary albumin excretion, slows the rate of decline in eGFR, and provides a greater chance of stabilization of kidney function in this high-risk patient population. Subodh, do you have any thoughts about that trial?
Well, thank you, Richard. It was really wonderfully presented, and thanks for such a concise and cogent summary. I think these are really important data because, as you mentioned, the interface between chronic kidney disease and diabetes is not only important in terms of progression of renal events, but we know that renal function and albuminuria and declining GFR are also prognostically and pathophysiologically linked to cardiovascular outcomes in people with diabetes. So strategies that improve renal function also improve cardiovascular function and reduce cardiovascular risk in patients with diabetes. So I think that the power of this pooled analyses really points to, the effects of GLP-1 RAs as being quite robust strategies at improving albuminuria. Now, in terms of whether these drugs do indeed have effects on declining eGFR rates or hard renal outcomes, I think that is being evaluated in some of the ongoing prospective studies, such as the FLOW trial, and we're going to learn a lot more about that. But I agree with you completely that this is an important analysis. It actually does extend, our understanding of GLP-1 RAs on renal protection. And, there are some limitations to the data. The data really are pooled from 2 large randomized clinical trials. These trials were not originally powered to evaluate kidney outcomes per se, and included patients with relatively low kidney risk at baseline. So we'll learn a lot about the efficacy of these drugs from a renal standpoint when the dedicated renal trials in people with advanced DKD are actually conducted.
Yeah, I think some people would say that this population in this paper were relatively low renal risk. And,
I would agree.
And I guess that's one of the caveats. But at least there was a consistency, I guess, between the 2 trials, which provides some confidence that it's a true effect.
Yeah, I agree with you 100%. Again, there's often discussion. Now, I'm not a nephrologist, but there's a lot of discussion around what could be the underlying mechanism or mechanistic basis for these benefits. And as you know, there have been some suggestions that this could be related to, natriuresis or, changes in reactive oxygen species production, reducing oxidative stress, reducing kidney inflammation, kidney fibrosis, or maybe even secondary to improved systemic hemodynamics or renal hemodynamics. So we won't know the exact mechanism, but there are several potential contributing theories and mechanisms that have been put forward.
Yeah, that's very helpful. Thanks. We should move on to the second paper.
Yeah, we'll get started on the second paper. And this paper by Agarwal and colleagues is entitled Empagliflozin and Incidence of Events Consistent with Acute Kidney Injury. This is a pooled safety analysis of over 15,000 individuals. By background, I think all of our viewers are quite familiar with the fact that SGLT2 inhibitors are widely used treatment options in people with type 2 diabetes and people with cardiovascular disease, at risk for cardiovascular disease, and those with diabetic kidney disease. And we also recognize that these drugs do cause an initial dip in the eGFR, and that has been postulated to be a hemodynamic recalibration, if I may, of glomerular pressures. And once you have that initial eGFR dip, we've seen consistently in the various trials that the GFR then stabilizes relative to declining eGFRs that are seen in people with diabetes who are treated with usual care or placebo. But having said that, there still remains some concern that SGLT2 inhibitors may induce acute kidney injury, or AKI, in certain groups of patients. And to be able to really understand this better, the authors have analyzed pooled safety data sets from 20 trials in the global empagliflozin clinical trial program to investigate specifically DKD in patients at risk of acute kidney events during the first 30 days after treatment initiation. So what they've done here is included people with type 2 diabetes who received empagliflozin either 10 or 25 milligrams per day, or those who received, let's say, dose escalation from 10 to 25 milligrams of empagliflozin. Over 15,000 were randomized to receive empagliflozin or matching placebo. And the primary endpoint was using investigator-reported adverse events to assess acute kidney injury and acute renal failure, so-called AKI and AKD events. So let me tell you a bit about the results that the authors have found. First, let's talk about the baseline characteristics. About 64% of participants were male in this analysis, and the mean age was around 60 in the placebo group and treatment groups respectively. The mean eGFR at baseline in the placebo group was 80 and was 82 in the treatment group. So you can see that, these are relatively, healthy, GFRs across the board. So again, majority men, mean age of 60, and baseline eGFR of 80 mils per minute. Microalbuminuria was found in a quarter of patients, and macroalbuminuria was reported in just short of 10% of patients in these two groups. Now, in terms of the key results, the incidence of acute kidney injury and acute renal failure, AKD, were numerically lower in the treatment versus placebo group, and you can see that on the slide presented here. The risk with treatment and placebo appeared to be similar. These AKI and AKD events increased with decreasing kidney function. The overall incidence rate was numerically lower in the treatment group than in the placebo group across all baseline treatment groups and baseline treatment demographics. There was no difference between the groups in the number of AKI outcomes that occurred within the first 30 days of treatment initiation. Specifically, there were 5 events in the placebo group, so that's really 25 per 100 patient years. And in the treatment group, there were 6 events, and that was really 0.72 per 100 patient years. There was also no difference between the groups in the number of AKD events occurring over this period. In fact, in the placebo group, there were only 18 events. In the empagliflozin group, there were 49 events. And overall, this was not different. 4.5 per 100 patient years in the placebo group and 5.9 per 100 patient years in the empagliflozin group. So overall, in terms of real summary and conclusions here, it's a very robust and large analysis of a clinically important outcome that often doctors in the trenches are thinking about often. And what the authors have found is that the number of kidney-related events consistent with either AKD or AKI within the first 30 days after treatment initiation was low and was generally comparable between placebo and empagliflozin treatment groups. While there were more reports of kidney impairment in the first 30 days of treatment, no initiation of kidney replacement therapy was reported during this period. And that really suggests to us that this may reflect what we call as the quote unquote eGFR dip that is known to occur with SGLT2 inhibitors or empagliflozin specifically, and other strategies that really has limited or low clinical relevance. So that's the summary, Richard, of the second paper. And certainly, if we have time, it would be wonderful to get any of your top line thoughts and comments on this publication.
Yeah, thanks, Ro. That's great. It's the sort of analysis I think a lot of primary care physicians will find reassuring, because we certainly still find that our primary care colleagues have been conditioned by the nephrologists to believe that drugs cause AKI. And so they're always very apprehensive about the risk of precipitating AKI, particularly with drugs that they know work on the kidney. So I think a lot of primary care docs will be reassured by this. And I guess one of my other questions, I'm assuming that a very high percentage of these patients were taking other blood pressure lowering drugs, renin-angiotensin blockers, and that similarly had no adverse effect when SGLT2 was added on top of some pre-existing therapy.
I think that's exactly the case here. Now, I don't know specifically the subgroup analyses of ACE inhibitors and SGLT2 inhibitors in this publication per se, but I've seen this in many other publications that SGLT2 inhibitors, when used in the context of background ACE inhibitors or ARBs, do not exaggerate the acute kidney injury risk. So these drugs don't cause AKI, and I think that's a really important message that we need to send to our listeners today. They actually prevent renal events, and they have quite a profound effect at renal protection. And while this analysis, as you know, Richard, has only looked at people with diabetes, we now have a lot of evidence beyond diabetes of these drugs in heart failure treatment, where you also do not see any evidence of acute kidney injury.
Yeah. No, it's a very useful, important analysis, and of course, safety data in the context of placebo-controlled randomized trials is the best of the safety data, which does give added reassurance that these 15,000 patients were all in blinded therapy. Great. Well, we should probably begin to wrap up with some concluding remarks. I think both of those papers have been really quite informative, and I would encourage readers to go and look for yourselves at some of the key learning points that come out of them. So thank you for joining us for this review. I hope you've enjoyed the brief podcast. You can let us know what you think by leaving a review.
And if you would like to view the publications uploaded this month, feel free to access the resources. Head over to the CMF, the Cardiometabolic Forum, at cardiometabolic.forum.com. We also encourage you to join our mailing list and follow us on social media so that we can try to stay in touch with you and let you know the moment an update goes live. So with that, thanks a lot. I hope you've enjoyed today's podcast.